Acid-base disorders, a systematic approach to pH, bicarbonate, and PCO2. A 45-year-old diabetic man presents with deep, rapid breathing and an arterial blood gas showing pH 7.22, PCO2 28, bicarbonate 11, and a glucose of 620. Another patient, a COPD patient on home oxygen, has pH 7.32, PCO2 68, and bicarbonate 38. What is happening in each case, and how do you approach acid-base systematically? Welcome to Medical Sciences Unfolded. Acid-base disorders are among the most tested and most misunderstood topics in medicine. Master the physiology, and any ABG becomes readable in seconds. The body maintains blood pH within the narrow range of 7.35 to 7.45. This is critical because enzymes, ion channels, and cellular processes are extraordinarily pH sensitive. Even small deviations cause serious dysfunction. Three major systems regulate pH: the bicarbonate carbonic acid buffer system, respiratory compensation via CO2 excretion, and renal compensation via bicarbonate reabsorption and acid secretion. The Henderson-Hasselbalch equation underpins all acid-base physiology. pH equals pKa plus log of bicarbonate divided by dissolved CO2. Since dissolved CO2 equals 0.03 times PCO2, the equation shows us that pH is determined by the ratio of bicarbonate to PCO2. Bicarbonate is the metabolic component, regulated by the kidneys. PCO2 is the respiratory component, regulated by the lungs. The four primary disorders, metabolic acidosis, low pH, low bicarbonate; metabolic alkalosis, high pH, high bicarbonate; respiratory acidosis, low pH, high PCO2; respiratory alkalosis, high pH, low PCO2. Step 1 in ABG interpretation. Look at the pH. Below 7.35 is acidosis. Above 7.45 is alkalosis. Step 2. Identify the primary disorder. If the pH is acidotic, is the bicarbonate low, metabolic, or the PCO2 high, respiratory? Step 3. Assess compensation. In metabolic acidosis, the lungs compensate by blowing off CO2. PCO2 falls. Expected PCO2 equals 1.5 times bicarbonate plus 8 plus or minus 2. This is Winter's formula. If the measured PCO2 matches this prediction, compensation is appropriate. If PCO2 is lower than predicted, a concurrent respiratory alkalosis is present. If PCO2 is higher, a concurrent respiratory acidosis exists.
In metabolic acidosis, the most important next step is calculating the anion gap. Sodium minus chloride minus bicarbonate. Normal is 8 to 12. An elevated anion gap indicates accumulation of an unmeasured acid. The mnemonic MUDPILES captures the causes: methanol, uremia, DKA, propylene glycol, isoniazide iron, lactic acidosis, ethylene glycol, salicylates. In our diabetic patient, pH 7.22, PCO2 28, bicarbonate 11. Primary metabolic acidosis. Anion gap equals 140 minus 105 minus 11 equals 24, elevated. This is DKA, a high anion gap metabolic acidosis from keto acid accumulation. The PCO2 should equal 1.5 times 11 plus 8 equals 24.5 plus or minus 2. Measured PCO2 is 28, slightly above predicted, suggesting a mild coexisting respiratory acidosis, but essentially appropriate compensation. Treatment: insulin, IV fluids, electrolyte replacement. Normal anion gap metabolic acidosis, also called hyperchloremic metabolic acidosis, occurs when bicarbonate is lost and chloride is retained. Causes remembered as HARDASS, hyperalimentation, Addison's disease, renal tubular acidosis, diarrhea, acetazolamide, spironolactone, saline infusion. The urine anion gap, sodium plus potassium minus chloride in urine, helps differentiate renal causes from GI losses. Metabolic alkalosis, high pH, high bicarbonate, is caused by vomiting, nasogastric suction, loop or thiazide diuretics, primary hyperaldosteronism, or bicarbonate ingestion. The kidneys compensate by retaining CO2, hypoventilation. Urine chloride below 25 suggests chloride-responsive cause like vomiting. Treat with IV saline. Urine chloride above 40 suggests chloride-resistant cause like hyperaldosteronism. Respiratory acidosis, high PCO2, occurs from hypoventilation, COPD, opioids, neuromuscular disease. The kidneys compensate by reabsorbing bicarbonate slowly over 3 to 5 days. Our COPD patient with PCO2 68 and bicarbonate 38 shows chronic respiratory acidosis with full renal compensation. Treatment targets the underlying ventilatory failure. Respiratory alkalosis, low PCO2, occurs from hyperventilation, anxiety, PE, early sepsis, altitude, pregnancy, aspirin toxicity. The kidneys excrete bicarbonate in compensation. Triple acid base disorders, where metabolic acidosis, metabolic alkalosis, and respiratory disturbance all coexist, occur in complex ICU patients. The delta-delta ratio, change in anion gap divided by change in bicarbonate, reveals whether a second metabolic disorder is hiding inside a high anion gap acidosis. A ratio below 1 suggests a concurrent non-gap acidosis. Above 2 suggests a concurrent metabolic alkalosis. Master this framework: pH, primary disorder, compensation, anion gap, delta-delta, and no blood gas will ever intimidate you again. Thank you for watching Medical Sciences Unfolded.